So just picking up from where we left, so I think we were trying to kind of talk about a situation without insurance versus a situation with insurance, and we said with insurance you could have three kinds of situations. You could have a co-insurance rate, you could have a co-payment, or you could have a deductible. And I think we stopped our discussion saying that if you had a demand curve without any kind of insurance, right, you would have a price and you would have a certain quantity or a certain demand for office visits at that price. And then if the insurance company negotiates a higher price with the physician without caring about that price, whatever price that is, if you have a higher co-insurance rate, then what will happen? If you have a higher co-insurance rate, then your demand curve would move in or out?
For the physician or for the people buying the insurance?
People buying the insurance, for the patients. If you have a high co-insurance rate, what will happen? Out or in? Swings in. What does a co-insurance rate mean? The co-insurance rate means that you have to pay a higher percentage, right? And last time when the class was over, Stephen asked me a question that, you know, why would a person be more responsive or less responsive? Why are you making big deal of the slope of curvature of the demand curve? Because, you know, we were dealing with that example where we said that $50, irrespective of which demand curve you were on, the out of pocket was still $50, right? In one case the negotiated price was $250. With the insurance, in one case it was $50, and then with the insurance it went up to $250, and then it went up to $500. So we did all those different cases. I'm not going into the details. You can flip the pages and see what I'm talking about. But the simple answer to your question, is here, the $50 is not the important part. Okay, the reason that you are on a different demand curve, that is the important part. Okay, the fact that you are on a different demand curve with insurance, or you are on a different demand curve when the co-insurance rate goes up or down, that is the bottom line here. Okay, so you don't have to worry, because you will not have any numerical calculations, and also not because of that, even from your understanding point of view, you don't have to worry about what is the absolute value of the out-of-pocket payment, or what is the absolute value of the negotiated price. What we are trying to hit here is that if you have an insurance and an insurance with a co-insurance rate, then that puts you on a different demand curve than a non-insured person, than an uninsured person. Or in other words, what we are saying is that the preferences of a person, because what is demand curve? Demand curve is basically a preference. How much of a good you prefer to have, how much of a good you are willing to have for a certain price. So basically the demand curve is a derivative of your preference, right? So the preference of a person having an insurance is different than the preference of a person who does not have insurance, and hence those two people are on two different demand curves, right? A person who has an insurance has a steeper demand curve than a person who does not. And similarly, if you compare between two people who have insurance, one having a higher co-insurance rate than the other, then the person who has a higher co-insurance rate tends to be on a flatter demand curve, right? Because he will be more responsive, because he is going to have a higher out-of-pocket payment. So you must remember that co-insurance rate just puts people on different demand curves. And why does it put people on different demand curves? It puts people on different demand curves because they are faced by different conditions, because demand is determined by those different factors. Remember, price and several other factors. So a non-insured person versus a person having insurance has a different set of factors altogether. So the demand curve is different. And not just the demand curve is different, the curvature of the demand curve is different. That is what you have to remember from here. Okay? So do not get too fuzzy, and do not get extremely worried about the numbers. because you don't have to work out the numbers. And also from the logical point of view, you must just remember this, that a person having coinsurance rate or having insurance just has a different preference and hence has a different demand curve. You cannot put the two people in the same demand curve because they are not facing the same set of conditions. They have different set of conditions. Okay? Now, the next part was about the second kind of insurance which can have a co-payment. Now, like I told you, the difference between a co-insurance and a co-payment is a fixed payment that you have to pay irrespective of the volume of the medical care cost, irrespective of the volume, irrespective of the price, the actual price. So, let us say the medical cost is $200, you have to pay $10. Even if it is $300, you still have to pay the $10. Okay? Or it may so happen that if the cost is $200, then you pay $10. If the cost anything between 200 to 500, you have to pay $10. Anything between 500 to 1000, you have to pay $20. Anything above 1000 to 1500, let us say $50. So, the co-payment could also be like that. It could be in tiers, it could be in levels, but the idea is that if you have an insurance, then you just have to pay that fixed amount. And let us say my medical cost is $100 while yours is $200. So, yours is more, but we still pay that same $10 co-payment. Do you see what I am saying? So, that means in this case you do have a demand curve, but that co-payment, that difference in co-payment, that higher co-payment or that lower co-payment is basically the out-of-pocket payment. So, that means that higher or lower co-payment is a movement along the same demand curve, isn't it? So, a person who has no insurance, that person's co-payment is 0. So, a person who has no insurance, that person has 0 co-payment, but that person's out-of-pocket payment is that entire cost, the $100. If you have insurance with a co-payment of $10, then that means that for you, your out-of-pocket payment is not 100 but 10, right? So, that is a movement downward along that same demand curve. Do you see what I am saying? And if you compare two people who do have co-payments, one has a co-payment of $10, another has a co-payment of $20, then the $20 person would have a higher out-of-pocket payment. Those $20 is his out-of-pocket payment. That is what is going out of his pocket. So, that would be a movement upward along that same demand curve, because remember, what are we measuring here? The out-of-pocket payment, be it through a co-insurance or through a co-payment. We are measuring how much is going out of the pocket. Earlier we were saying the demand for healthcare. Did I say QD? Did I say QD last time for demand for healthcare, or did I use something else? QD. Demand for healthcare, that depends on price plus certain other things which are non-price. Now, this price we said is we are kind of using a proxy for that price, which is the out-of-pocket payment, because we cannot use the price of 10,000 different things that can be included under healthcare. So, we are just saying out-of-pocket expenditure or out-of-pocket payment. Now, with co-insurance rate, your insurance has a certain co-insurance rate. Her insurance has a different co-insurance rate, which makes your demand curve different from her demand curve, because the underlying condition is different. Do you see what I am saying? That is why you as a consumer, given your co-insurance rate, you are a different consumer than her, and hence you may have a flatter or a steeper demand curve. Now, as far as the deductible is concerned, I don't think your lecture note says anything in terms of the diagram for the deductible, right? If you have read lecture note 4, your lecture note 4 does not refer to the diagram, does not refer to the figure in terms of the deductible. Now, what happens? Big yawn.
Sorry. I am listening.
Okay.
Very interesting. Very, very interesting.
So, in terms of in terms of the deductible, what is a deductible? Deductible is like you have to meet a certain threshold and then your insurance is going to kick in. So basically, let's say you can have a deductible of $500. As long as your expenditure is up to that $500, that entire money is your out-of-pocket payment. Once you have met that $500, then it's going to be like a co-insurance rate, right? You pay 10%, insurance pays 90%. And then there is again a threshold after which you basically become fully covered. So your co-insurance rate basically goes down to 0%. So that means deductible is a combination of all three. Do you see what I'm saying? So if you look at the picture, if you look at that entire horizon of deductibles, till that first threshold, it is something like a copay, isn't it? Where your entire cost of treatment up to that threshold is going out of your pocket. Do you see what I'm saying? After that, it becomes something like a co-insurance rate, and also there may be variation in that rate at different thresholds. Up to say up to 500, you know, everything goes out of your pocket. Once you have met 500, then you pay 20%. Once you have met 2000, then you have to pay 10%. Things like that. So it has different categories or it has tiers in the deductible system. So that's why your lecture note, I mean in the textbook it did have reference to the figure, but I deliberately did not give you those pages because it makes the diagram even more critical. That means up to a certain threshold, whatever is the first threshold of the deductible, that would be the relevant demand curve, right? After that threshold, depending on whatever is the co-insurance rate, that demand curve is going to swing out like a co-insurance rate. So basically what you have is a kink in the demand curve. Your demand curve is that and then this. Do you see what I'm saying? Where this is basically that threshold, 500, 800, 900, whatever it could be. So if you have a high deductible plan, then the kink of the demand curve is going to be on the higher end. And if you have a low deductible plan, then the kink of the demand curve is going to be at the lower end of the curve. Are you following? So that means deductible, if you had to kind of analyze a deductible plan in terms of the diagram, it would be a combination of a copayment and a co-insurance case, right? And something that I did not mention last time, and that was also deliberate, that means now you can kind of differentiate between two kinds of demand curve. One which is your effective demand curve, the other one which is your nominal demand curve, right? So that means this is your actual, when you are drawing the first demand curve, that is your effective demand curve. Had there been nothing, had there been no intervention from insurance, this is the price, out of pocket payment, that is your demand for medical care, and you have the demand curve. That's the effective curve for you. Now when you are adding impurities to the system, or when you are adding intervention in the system, be it through copayment or co-insurance or deductible, that is when you are seeing differences in this demand curve, right? Rotation or whatever. So that demand curve, that change demand curve is called the nominal demand curve. Why is it the nominal demand curve? It's the nominal demand curve because it is influenced or nominated by certain other factors. It is not what you would do, or not what, it does not represent your actual demand. It's your demand which has been influenced by something else, and that something else is the condition of insurance that you are facing, be it the co-insurance rate or whatever. Do you see what I am saying?
When you say that kink causes a change, is it causing a change in demand for insurance or a change in the price?
What? This kink? I am saying the deductible is causing the kink.
Which does what? Changes the demand for insurance in general, or just causes movement on the price line?
See, insurance is not in this diagram. Once again, this is not the diagram for insurance. This is the diagram for physician services we were doing, I think, last time, or any kind of medical care. That is the market. Do you see what I'm saying? So this is your demand for physician services. So what I'm trying to say, I'm coming to you, what I'm trying to say is if you have a deductible plan, then up to that first threshold where you must meet that, that entire money goes out of your pocket. So whatever is your effective demand is also your nominal demand. There is no change because you are paying that entire money. Although you have insurance, that insurance is not kicking in before that threshold. Do you see what I'm saying? After you have met that threshold, then your insurance is kicking in. And it is kicking in the form of a co-insurance rate. And as soon as it is kicking in the form of a co-insurance rate, it is causing a rotation of the demand curve. So that means now your demand curve will basically look like bad at drawing. Something like this, where now you have a kink here, and what is that kink? That kink is that first threshold of that deductible plan, whatever you have to meet, whatever deductible you have to meet. So now your demand curve looks like that, whereas your effective one would have been just like this, but your nominal one is kinked. In case of your co-insurance plan only, that would have been your effective and that would have been your nominal without any kink. And in case of your co-payment plan, the effective and the nominal would have been the same, just that with the co-payment you would have seen a downward or an upward movement along that same demand curve. For example, my plan, okay, the plan that I have, my first is 800. So up to 800, everything I have to pay. Okay, so that means all that 800 is my out of pocket, so my effective coincides with my nominal. After 800 up to $2,000, I have to pay say 20%. Okay, so then this is the effective demand curve for 20%. Okay, up to 20%, that is my nominal demand curve. And my effective demand curve would have been just like that, but my nominal is the rotated one because that is my co-insurance over there is 20%. After 2000, my co-insurance is 0. Everything that I pay after 2000 is picked up entirely by my insurance company. So that means there, after that point, my nominal demand curve is that. And then after 2000, this becomes the nominal. So there are breaks. That's why I didn't give you the diagram. It's a critical diagram. But are you following the logic, basically?
I'm not getting the nominal versus effective part.
Nominal is what you have after insurance. Okay? Effective is what you have without insurance. Simply put. Effective is before insurance, nominal is after insurance. In the co-insurance plan, you have one single downward sloping effective and you have a single downward sloping nominal. The only difference between effective and nominal is the slope. So if you have a co-insurance rate, then your nominal curve will be steeper than your effective curve. That's for co-insurance. For co-pay, you also have a nominal, but in that case the nominal and the effective coincide. So you cannot distinguish between the two. Okay? They coincide. Only way you can distinguish whether there is a co-payment, high co-payment, low co-payment is by looking at the movement along that curve. Whereas for deductible, it's a combination of the two cases. Combination in the sense that up to the first threshold of the deductible plan, where you have to meet that money for your insurance to kick in, there the nominal and the effective coincide. You just have one single demand curve. After that threshold, the co-insurance rate kicks in and your demand curve rotates out. it has a different curvature. And even after that, if you have a second threshold after which your coverage is maximum, like it's 100%, your insurance company picks up all the costs, that means there your demand curve becomes perfectly inelastic or vertical.
And that's the nominal.
That's the nominal. That's the nominal. Anything after insurance is the nominal one. So in that case, it would look like that. So I guess what you need to remember is that you need to remember the difference between the nominal and the effective. That is, what is the difference between the two, and why are we differentiating between the two? Okay? We are differentiating because we are considering two situations for the same individual. One without insurance, the other with insurance. And then, while we are studying the difference between nominal and effective, we are looking at three different cases of insurance. One where there is a co-insurance rate, one there is a co-payment rate, and the other one where there is a deductible. Yes?
So essentially by these curves, what we're saying, these are demand curves. The less I have to pay, the steeper that's going to get, and the more my demand for insurance, for physician services is going to go up. All right, I just wanted to clarify.
Not the demand, not the demand for physical services, not the demand for physician services, my responsiveness. Here we are talking about the curvature. Please note, we are not talking about the demand curve, we are talking about the curvature. How insurance affects my responsiveness. That is what we are talking about. So what the first part of your statement was absolutely correct. That when you have insurance, your curve is just going to go steeper because you pay less out of your pocket. You have a buffer. Somebody else is covering. The insurance company is picking up a part of your burden. Now in the same chapter, in the demand for health, now we are going to go one step further. So now we know the basic framework for demand for health, okay, and we have kind of compared it with whatever we have learned theoretically in terms of demand and supply and elasticity. That part is done. Now we are just going to develop a new model, or we are going to look at an innovative model for demand for health. And what is the purpose of this model? The purpose of this model is to differentiate health or categorize health as two different kind of goods. So this Grossman model, 1972, it just looks at health and says that health can be looked at as two different kinds of goods. It's not just one kind of good, you can perceive of health as two different kind of goods. In other words, this Grossman model is basically an extension of human capital theory in economics. So in economics, we have a very famous theory, which is the human capital theory, and Gary Becker, an economist, won the Nobel Prize for this theory, proposed in 1965. So the Grossman model is basically an extension of the human capital theory to healthcare and health. It's a special case of the human capital theory. Okay? Now, like I told you, the Grossman models, the main objective of this model is to define health in two different ways, or to say that health is two kind of goods. You can consider health to be two kind of goods. The first is health is a consumption good. Okay. What do I mean by that? It means that every individual has a stock of health, and that stock of health is a good which is intangible, and it is not tradable. The stock of health is intangible and not tradable. That means you have a certain, it is something that you cannot see, or you cannot move around, or you cannot buy or sell. Okay? Then what is this? This is basically the current state of your health. The stock of health is the current state of your health. So two people in the same age, having the same demographic conditions, having the same profile, may still have different stocks of health, just because their current health status is different. If you ask me how are you feeling today, I may say excellent, and another person having the same nationality, same origin, same age may say that that person is feeling fair or good, not excellent. So that is what we are talking about. We are just talking about the current status, health status. That is the stock of health. It is intangible and not tradable. That's the first characteristic. The second characteristic is that there is a demand for this health as a consumption good. It is demanded. That means an individual is better off when he or she has a higher stock of health than a lower stock of health, right? So I would prefer to say that I am in excellent health rather than saying I am in poor health. So more of that stock is better. Do you see what I am saying? And by more here, I do not mean any parameters. I am not talking about blood sugar level or blood pressure level or anything of that sort. I am just talking about the status. So a better status is always desired by the individual, and in that sense it is a consumption good, because that is the definition of a consumption good. A consumption good is anything which you want to consume more and more of it. You want to have more of it because you have a benefit attached to it. You have a utility from it. So similarly, we are saying health is a consumption good because it is demanded, and it is demanded because there is a utility attached to it. There is a benefit or utility that people get by having a higher health stock. Okay. What is that benefit or utility? That benefit or utility is that you have more ability or higher ability, or let us say more time to earn higher income or wealth. Okay. So if you are healthier, if you think your current health status is better than somebody else, then you are in a position, you will probably fall sick less times in the year, hence you will have less sick days, which means you will have more time to productively use your working time. That means you have a better opportunity to earn a higher income or wealth, and that is exactly what you see in the real world. If I am a person with 3 chronic illnesses, while you are a person who does not have any chronic illnesses, due to my chronic illness, I may be bedridden for 3 months in a year, right? And you may be working for all 12 months in a year, then my yearly income is only 9 months of my whatever I earn in the 9 months, whereas you may be earning all 12 months. So you have a better opportunity for earning a higher income and a stream of wealth over your lifetime than me, right? And since I want to be like you, that's why this is valuable for me. Since I want to earn more income and more wealth, that's why this is valuable for everyone. That's why I would rather want to have a better stock of health or a state of health than a worse state. Is that clear? Okay. Do you understand what I am trying to say? So this utility, so you can look at it as a utility or disutility. So the utility is a better opportunity for earning higher income, or the disutility is the sick days. So you don't want the disutility, you want less number of sick days, and you want the higher utility or the benefit. That means you want the more income or the wealth, right? Is that clear? Now please note that there may be, now this is something, if you think about education, it is the same logic, right? It's the same thing. That means somebody wants to invest in education, a person wants to be more educated than another person because that person thinks that that education is going to bring some benefits. And what is that benefit? That benefit is probably higher income. So a person invests in education because he thinks that education is going to bring some return in the future. Similarly for health, you invest on your health, you want better health because you think you are going to benefit from that better health. Okay? Is that clear? And that's why, you know, education, health, they all come under the human capital theory, where you are basically trying to improve yourself as a worker. You are doing something to improve yourself. The basic crux of that theory was as a labor, As a worker, you are doing some investments on yourself, either through better education or through better health or better lifestyle, to improve your quality and your ability or your productivity as a worker. Okay? The Grossman model is just singling out the health part and saying that when you invest on health, your motive is that you want to earn higher benefit from that, and that higher benefit is in the form of higher income, possible, potential higher income and potential higher wealth. And since you do this, that's why health can be called a consumption good, because you want to consume more of it. Now, that was one part. The second part in the Grossman model is that health is not just a consumption good, but health is also an investment or a capital good. Now, what do I mean by that? An investment good or a capital good? That means this good can be produced, it can be produced or improved using some inputs. That's one. And secondly, this good depreciates over time and needs maintenance. Okay. So now what am I saying? I am saying, so this is the stock of health. Now remember, that's intangible, right? It's an intangible, not tradable good. But to maintain this stock of health or to improve this stock of health, I could be using some other goods. And medical care is one of those other goods. So medical care is one of the inputs that I can use to produce a higher stock of health, right? Let's say today I am not feeling good, I go to the doctor and I take medicines for 7 days. After 7 days, I will feel better than today. So what has happened in the 7 days? The stock of health has gone up, right? In other words, I have created an improvement in the stock of health. Now this improvement is not visibly seen, but what can be visibly seen is what I have done to make this improvement. And what have I done here? I have used physician services, I have used medical care. So this medical care part or the inputs part, that is the tangible part. Are you following? So you have something intangible, you have something abstract, which is your stock of health, and we are saying that this stock of health is a consumption good, so you demand better health, you demand better health status, because you think that there are certain returns that you can get from this better health, and that return is usually in the form of less number of sick days or more opportunities for earning higher income and wealth. And the second point is that this good is not just a consumption good, but this good is also an investment or a capital good, which means you can use different other things to improve this good. And what are these different other things? These different other things can be medical care, like physician services, medicines, it can be better lifestyle, it can be better diet, it can be exercise, right? So you can use those inputs to improve your stock of health. And while you cannot see the improvement, you cannot visibly see the improvement, but you can see the inputs that were used to make that improvement. Okay, is that clear? So please remember that medical care, so now we are kind of differentiating between health and healthcare. So we are saying this is about health, which is the stock, and these inputs is the medical care or the healthcare. So one is just health, which is the intangible stock or your status, health status. The other is the health care or the medical care. So what am I basically trying to say? I am trying to say that by using health care, you may be able to improve your health. Okay? That's one part. Now coming to point number 2, you know that since this is about human beings, over time this health stock will depreciate. And since it will depreciate, that means no matter what you do, just by the virtue of age, your stock of health is going to decline over time. Usually a healthy individual, 20 years old, has a higher probability of earning higher income and wealth than a healthy person who is 90 years old. Just his age has caused some depreciation in his stock of health, right? So it will depreciate over time, the stock of health will depreciate over time, but some of that depreciation can be offset or compensated by maintaining it properly, right? So that means in both these points, in point number 1 and point number 2, you can see that health care is necessary for maintaining the stock of health. In the first case for improvement, in the second case for maintenance, right? So can I say from these 2 points, can I deduce that the demand for health care, please write this down, the demand for health care is derived, and please underline derived, it is derived from the demand for health. Very important. So that means later on, after this chapter, when we talk about different kinds of healthcare, when we talk about physician services, when we talk about nursing services, when we talk about hospital services, all that, all those kinds of medical care or health care, those are all derived demand. They are all derived demand. If I ask you today, just without anything, without any concept of stock or capital good or consumption good, anything, do you want to get yourself admitted at the hospital? You will say, hell no. Why? Right? Or if you say, if I just ask you, do you want to have some, whatever, some kind of, I don't know the name of medicines, but some heart, do you want to go through anesthesia? Just like that? No. Right? So healthcare on its own is not a pleasurable commodity. You don't want to consume it. The reason that you want to consume it is because you want better health. So it is derived from your demand for health. So what you demand is better health. And since you demand better health, that's why you need all those inputs. Right? So healthcare is a derived demand. Please remember, that is what sets the difference between healthcare with other commodities. If I ask you, do you want to eat an ice cream? You will say, yes, of course. Because that's good. You want to eat it, you enjoy it, you get some pleasure directly out of it. But the same is not true for some kind of medical care, right? You demand it because you want better health. So it's a derived demand. Any questions so far? Okay. Now, so you are using these inputs for making the improvement. Now, also please note that this using, how you use the inputs, how you use the medical care, that also depends, that also varies from person to person, right? I may be wanting to be in better health and you may be wanting to be in better health also, and we may be visiting the same primary care physician, but what I do with the physician's advice may be different from what you do with the physician's advice. And that difference could be because of our backgrounds, it could be because of our knowledge, it could be because of our education, or it could simply be because of how we are as a person. I could be a person who loves risk. I may be a risk taker. You may be a defensive person who is risk averse. So this, how we use the inputs can also be very different, although the target level may be the same. So I may want the same level of health, or I may want the same health status as you, and I may be using the exact same inputs, but how I use the inputs or how efficiently I use the inputs may depend, may vary based on our other conditions, right? Something like education, or our knowledge, or just our attitude. Is that clear? Okay. So, that means while I want to improve my health using healthcare, and I will mention this once again, and you have to remember this, that healthcare is just one input, okay, for better health. There could be other inputs also, but we are specifically talking about the relation between health and healthcare in the context of the Grossman model, okay. Now, you can understand that since it is a consumption good and hence there is some utility that can be that you can get from health, and that utility is better potential income and wealth, that means there is a marginal benefit which comes from the fact that it's a consumption good. So, you have some benefit from that health stock, right, and that benefit could be either less number of sick days, or that benefit could be higher possibility of earning income, okay. And there is also a marginal cost. What is the marginal cost? The marginal cost, now you can look at that marginal cost from 3 different ways, or in other words, that cost can have 3 different dimensions. The cost that you incur for better health can be of 3 dimensions. First, the direct cost. So, you buy the health care, you go to a physician and you pay a price, you get yourself admitted at a hospital, you have to pay a price, you have to buy medicines, you have to pay a price. So, there is a direct cost for improving your health. That means the cost of the healthcare input, right, that is a direct cost. The second is the depreciation rate itself, that is a cost to you, isn't it? With age, it is depreciating, your health is depreciating, that is a cost to you. There is a third cost, which is the opportunity cost. What is that opportunity cost? If you are unhealthy, if you have to take off, then there is a foregone income. There is a sacrifice in income, that is also a cost to you, isn't it? So, that means there is a benefit that is attached to health, the stock of health, and there is a cost, and that cost has different dimensions which comes from either the direct expenditure on the inputs which are required to improve your health or maintain your health, and the cost which comes from the depreciation or the loss of income due to ill health. You want more of stock, and you want more of stock because you do not want to be sick, or you want to earn higher income, and you know that better health will give you a better possibility of earning a higher income. Okay, so, that is direct, but the cost part is tricky because the cost is coming from, you can analyze the cost from different aspects. It can just be the direct cost, that okay, I need better health, so I have to buy more healthcare inputs. So, it is a direct cost. I need to go to the doctor, I need to go for rehab, I need to go for, I need to buy medicines and have my medicines regularly. Whenever I am if my health gets worse, then I have to go and get myself at the hospital. So, those are the direct costs. But there is also a depreciation cost. Over time, your health is declining. So, you have to maintain that. So, the depreciation is also a cost to you, right? And thirdly, there is an opportunity cost, that if you fall sick, there is a possibility of lower income. There is a possibility of sacrifice that you have to make in terms of your income. That is also a cost to you, right? So, on one hand, you have the benefits of staying healthy, and on the other hand, there is a cost of being unhealthy. So, there is a benefit of having higher health stock, and there is a cost of having lower health stock. As long as this benefit is greater than that cost, you will want to raise your health stock, and I am just calling it H, which is basically your health stock. As long as the benefit is greater, you will want to raise it, you will want to improve your health stock, isn't it? If that cost is greater, that is when you think about, that is when you deliberate whether you should increase or not, right? So, as a rational individual, since in economics we only deal with rational individuals, as a rational individual, you weigh the benefits. In other words, you weigh the utility of additional healthiness, because remember we are doing marginal. So, marginal always means the additional, right? So, you basically weigh the utility or the benefit from additional healthiness versus the cost of additional healthiness, right? Do you see what I am saying? So, it is a cost benefit, it is once again a benefit and cost analysis that you do, right. Now, let us concentrate on these benefits and costs, and let us see can we capture it in a diagram.